Ma'am, we are live.
I welcome everybody on this webinar on Independence Day on Corneal Biomechanics. It is not just for the scientists anymore, and we have a galaxy of speakers today with us on this webinar who are going to reveal the secrets of corneal biomechanics. I have Professor Mahipal Sachdev, who is the President of All India Ophthalmological Society and Chairman and Medical Director, Center for Sight Group of Eye Hospitals. Professor J.S. Titial, who is the Professor and Head Cornea, Cataract and Refractive Surgery Services, RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences, New Delhi. Dr. Rohit Shetty, who is the Vice Chairman of Narayan Nethralaya Eye Institute, Bangalore. Professor Rajesh Sinha, who is the Honorary Treasurer of the All India Ophthalmological Society, Professor of Ophthalmology at Cornea, Cataract and Refractive Surgery Services, RP Center, AIIMS, New Delhi. Apart from this, we have Dr. Prema Padmanabhan, who's the Director of the Cornea Department, Shankar Nethralaya at Chennai. Dr. Shizuka Ko, Associate Professor, Department of Innovative Visual Science, Osaka University Graduate School of Medicine. Dr. Tommy Chan, who's the Clinical Assistant Professor, Department of Ophthalmology at Department of Ophthalmology and Visual Sciences, Hong Kong, and Dr. Vaishal Kenya, who's the Chairman and Medical Director, Kenya Eye Hospital, Mumbai. So I would now request our President, Professor Mahipal Sachdev, President, All India Ophthalmological Society, to say a few words.
Thank you very much, Dr. Namrata. And in the first instance, I'll wish to greet everyone warmly on the 74th Independence Day of India. Indeed, a proud moment for all of us, where India is undergoing a transformational change. And I think these transformational changes can be seen in ophthalmology as also in other fields. I think Indian ophthalmology has really carved a space for itself in the global field of ophthalmology, with a lot of clinical work and nowadays also a lot of research work coming out of the Indian ophthalmologists. Corneal biomechanics, I would say, is one of the topics that has been catching the attention of all ophthalmologists, as refractive surgery has taken strong footings in the entire world. I think what was little understood earlier is now being understood more and more with the new advances in the techniques and technology that is being introduced to understand corneal biomechanics. Earlier, we all thought that it is only the scientists who are trying to postulate certain things, but I think the clinical applications of these new technologies has made refractive surgery much more predictable and much safer than what it was. Because when you're working on refractive surgery and the cornea, I think it is very, very important for us to not cause any harm or damage to the individual who's come to, say, get rid of glasses. So I think this is a very important topic that we have a lot of experts from India and overseas, and I think we wish to thank the organizers for having got on Dr. Ko, as also Dr. Tommy Chan from Hong Kong and Dr. Ko from Osaka. So Rohit, as we all know, is the torchbearer of, I would say, research in India. To his credit and to NN, I think they have set up fantastic labs, and there are other organizations also which are working on it. But I think in the field of the corneal biomechanics, the contributions of Dr. Rohit has been unparalleled. Dr. Prema, I still remember, had come over to Apollo hospitals way back in the 90s, late 90s, to do a live surgery demonstration on refractive surgery. That was my first workshop that I had organized, I think in 1996 or 97, as I have left the All India Institute of Medical Sciences. And we have Dr. Kenya, who is also a great refractive surgery and surgeon. And above all, I think my dear friends, colleagues who have been my colleagues or my students, Professor Titial, who is, I think, one of the finest cataract surgeons and refractive surgeons as also corneal surgeons today. And I think Namrata and Rajesh, who are doing great work along with Dr. Tritial in All India Institute of Medical Sciences, as also I would say both of them as a team are working relentlessly and tirelessly in the All India Ophthalmological Society to take things forward and to keep the morale and the intellectual uh, inputs that are being given from AIOS through these webinars to the members is something that is commendable. So I think without much ado, I will wish to have the session started, and I also have the pleasure of welcoming Professor Shizuka Ko, who is a PhD MD and is an associate professor in the Department of Innovative Visual Science at the Osaka University Graduate School of Medicine. She received her MD from Osaka University Medical School in 1999, and after a research fellowship at Osaka University and at the University of Rochester, she has pursued quality of vision in corneal and ocular surface diseases and has research interest in visual functions, dry eye, corneal diseases, keratoconus, and corneal ectatic diseases and contact lens. She has published over 100 peer-reviewed articles as well as book chapters, and Dr. Ko has presented her work and has been invited speaker for several national and international meetings in numerous occasions on topics in cornea and external diseases and visual sciences. She has also received the Achievement Award from the American Academy of Ophthalmology. I welcome you and thank you, Dr. Shizuka Ko, for having joined this particular webinar on corneal biomechanics. And with that, I think I'll pass it on back to Dr. Namrata, who can take the proceedings forward for this webinar, which is going to be interesting, I'm sure. And all of you are requested to do post your questions, and we shall ask the experts to answer them as and when they come. Thank you.
Thank you so much, sir. And we have another international speaker today, Dr. Tommy Chan, and I request Dr. Rajesh Sinha to introduce Dr. Tommy Chan.
Thank you, Dr. Namrata. It's a great pleasure to introduce Dr. Tommy Chan, who is a specialist in ophthalmology at the Hong Kong Sanatorium and Hospital. He is also a clinical assistant professor in the Department of Ophthalmology and Visual Sciences of the Chinese University of Hong Kong and the Department of Ophthalmology of the University of Hong Kong. His special interests include corneal refractive procedures, cataract surgery, keratoconus, corneal cross-linking, and anterior segment imaging. Dr. Chan has numerous publications. He has published over 130 articles in peer-reviewed journals and has many chapters in textbooks. He was awarded the APO Achievement Award in 2018. He is currently the treasurer of the Asia Pacific Ocular Imaging Society, honorary secretary and council member of the Hong Kong Ophthalmological Society, director of the CUHK Jockey Club Ophthalmic Microsurgical Training Program for laser refractive surgery and cataract and lens surgery, director and honorary secretary of the Hong Kong Federation of Societies for the Prevention of Blindness. It's a great pleasure and honor for us. We welcome you, Dr. Tommy Chan.
Thank you, Rajesh. And now I think we'll begin with the first talk of the day, and that is by Dr. Shizuka Ko. She's going to be speaking to us on clinical significance of corneal biomechanics.
So, hello, can you see my presentation?
Yes.
Yeah.
Okay. Thank you for the kind introduction. Good afternoon, everybody. Okay, first of all, happy Independence Day. It is my great honor to be invited here and give a talk on this special day. I'd like to thank AIOS committee members and Oculus for this opportunity. I hope you enjoyed the introduction. In my talk today, first I will talk about corneal biomechanics and its role in ectasia. Then I will introduce joint use of the pentacam and Corvus ST for ectasia detection, showing some cases. The cornea is not a piece of plastic. This is a very famous phrase by Professor Cynthia Roberts, who has made a great contribution to the field of corneal biomechanics. The cornea exhibits both viscous and elastic biomechanical behavior. Elasticity is usually used for solid. It is the ability of a body to change its shape when a force is applied, and to return its original shape when the influence of the force is removed. Viscosity is generally used for liquid. It means a measure of its resistance against progressive deformation. What is stiffness? It is the overall rigidity of an object. Stiffness is defined as a measure of the resistance against elastic deformation as a response to the applied force. It is dependent on several factors. Let's think of a basketball and a beach ball as examples. When we think about their stiffness, we should consider material, thickness, internal pressure. Material of these balls are totally different. The basketball is hard and not easy to deform, but the beach ball can be deformed easily. When we compare the balls with the same material, stiffness is higher in thicker balls or balls with higher internal pressure. When we think about cornea, material in cornea means corneal biomechanics. Thickness is, of course, corneal thickness. Internal pressure means IOP. So stiffness of the cornea is dependent on corneal biomechanics, corneal thickness, and IOP. The pathophysiology of keratoconus is likely to include the following components: genetic disorder, biochemical disorder, biomechanical disorder, environmental disorder. What is corneal ectasia? This is biomechanical change of the cornea leading to thinning and protrusion of the cornea. Also, it leads to a progressive astigmatism with irregularities. If it progresses strongly, possible keratoplasty or potential blindness might be considered. This is the theory of development of ectasia. Before corneal curvature or thickness changes due to the disease, the corneal stiffness and elasticity is already changed. Therefore, corneal biomechanical assessment is crucial for detection of subclinical ectasia. As clinical significance of corneal biomechanics, I can mention following things. Assessment of accurate IOP is helpful for consideration of glaucoma risk factor. Regarding to keratoconus and ectasia, it is useful to detect subclinical status and to monitor progression and efficacy of corneal cross-linking. Corvus is a novel no-contact tonometer that allows investigation of the dynamic reaction of the cornea to an air impulse. It is based on ultra-high-speed shine-proof technology. Shown here are the obtained movies from normal eye and keratoconic eye. This is a dynamic corneal response display. Several of these parameters are shown. Shown here is the Bench-Guerra screening report. At the bottom right of the screen, there is a box with 5 parameters. These are first 4 parameters, and colored one at the right end is Corby's biomechanical index, CBI. This is calculated based on the corneal thickness profile and deformation parameters. Let's take a look at these parameters a little bit more. I believe that some of you are not familiar with them. I'm going to explain them very simply as a clinician. Except for ARTH, other 3 parameters are purely biomechanical parameters. We will focus on these 3 parameters. DL ratio 2 mm is calculated based on the ratio between the deformation amplitude at the corneal apex and the deformation amplitude at 2 mm nasal and brow from the apex. Softer corneas start to deform only in the center, where the placentral part of the cornea deform much less. Therefore, the DL ratio is higher in softer corneas than in stiffer corneas. The central radius of curvature is calculated during the concave phase of the deformation. Softer cornea exhibit a smaller radius, so the inverse radius is higher. The area under this inverse radius versus time curve is determined, and it is called integrated radius. Thus, the integrated radius is higher in softer corneas than in stiffer corneas. Stiffness parameter is calculated based on the difference between the strength of the air pulse at the corneal surface and the biomechanically corrected IOP, BIOP. The displacement of the central apex at the time point of first vernation is measured. Therefore, the stiffness parameter is lower in softer corneas than in stiffer corneas. Again, CBI is calculated based on the corneal thickness profile and deformation parameters, and ranges between 0 and 1. It is useful for detection of clinical and subclinical keratoconus. Let's quickly revisit tomography. When you read tomography, you begin with ABC. Yes, A for anterior surface, B for back surface, and C for corneal thickness. Now you understand the softer cornea has high barrier in deformation amplitude ratio and the integrated radius, and lower values in stiffness parameter. Do they correlate with the severity of keratoconus? We investigated the correlation between corneal biomechanical parameters and severity of keratoconus based on tomographic parameters, yes, ABC. CBI beta is kind of raw data of CBI here. Instead of values between 0 to 1, it shows the real values. As you see here, they are well correlated. Therefore, biomechanical indices correlate with KC keratoconus severity. As one of the updates, biomechanical comparison display is newly introduced. It can provide visualization of biomechanical changes over time. It is useful to track patients, especially pre and post-treatment. Okay, let me share with you cases from our clinical practice, not in a galaxy far, far away. Keratoconus generally present bilaterally, although often asymmetrically. In certain very asymmetric ectasia cases, the contralateral eye may present firm first keratoconus, FFKC. According to the global consensus on keratoconus and ectatic disease, true unilateral keratoconus does not exist. However, a unilateral clinical presentation may occur. Pentacam has a nice program called Belin ABCD progression display, which grades these ABCs. We retrospectively examine the ABC data in fellow eyes of very asymmetric ectasia for 6 years. As you see, these parameters were stable over the observation period. There is no obvious progression. On the basis of tomographic evaluation, true unilateral ectasia can exist. The recently introduced Tomographic and Biomechanical Index, TBI, combines Scheimpflug-based corneal tomography and biomechanics. It can enhance ectasia detection. This is a case of VAE. The right eye is VAE with normal topography, FFKC eye. Let's look at his tomographic and biomechanical data. Yes, okay. Both BAD and CBI were low values and within normal range. However, only the TBI, 0.31, is abnormal. Actually, cutoff value I used was more than 0.29. So only the TBY was abnormal. Subclinical ectasia was detected only by TBI. We may call such kind of eye as very asymmetric ectasia with normal topography and normal tomography. This is another case of VAE. The left eye is VAE with normal topography, FFKC eye. Interestingly, all the parameters, including placido, BADD, CBI, and TB, are completely normal. We may consider that this case is kind of true unilateral ectasia, not true first case. Recently, several papers from the different countries reported that TBI was useful in detecting subclinical ectasia in eyes with normal topography in VAE patients. In our TBI validation study in Japanese population, 60% showed abnormal values at least in one parameter. However, 40% showed all normal values. Probably these cases may be unilateral ectasia. Therefore, I could say that TBI may allow separation of true unilateral ectasia from true first cases. When the patient is referred for refractive screening, we normally do everything. In addition to standard exams, we do topography, tomography, biomechanical, wavefront, OCT. Multimodal imaging is helpful in diagnosis of borderline cases. Also, we perform the questionnaire for keratoconus-related risk factors. Shown here is my current cutoff values for normal. This is a very asymmetric ectasia, VAE, with normal topography. As you see, only the CBI was abnormal. In such case, we keep observation. We experience such cases where CBI at only one visit was abnormal. This is a very asymmetric ectasia, VAE, with normal topography. As you see, only the bad D was abnormal. Of course, in such case, we keep observation. I think this is the best way. Many teenagers are referred as suspect keratoconus for further examination since they have high astigmatism or from other reasons. Consideration of keratoconus-related factors such as familial history, eye rubbing, sweep face down, atopy, and ocular allergy is important because in some cases, keratoconus progression seems to be aggressive and rapid compared to the older age groups. Dr. Renato Ambrosio in Brazil is actively working for keratoconus awareness campaign named Violet June. If you go to the website of Dr. Damien Gatinel in France, you can find both doctors emphasize the importance of patient education. Stop eye rubbing. Thank you very much.
Thank you so much, Dr. Shizuka, for that very nice presentation and for clearing the basics of corneal biomechanics. Now I request Dr. Prema Padmanabhan ma'am to give her talk, and she will be talking to us about a new parameter that has been introduced, and that is the stress strain index. Does it add any value?
I have one question for Dr. Ko.
Yes.
You talked about three important things. One was bad, second was CBI, and third was TBI. In three examples, you rightly said if bad is abnormal, we'll follow up the patient. If CBI is abnormal, we'll follow up the patient. But your first example where bad and CBI was normal, but your TBI was abnormal, what about those cases? We should follow those cases also?
Yes, yes.
So I think all three cases need to follow for a 6 months to 1 year before we label them as a case of keratoconus or no keratoconus.
Okay, thank you for the question. Actually, I didn't actually show the long follow-up cases, but definitely, actually, I have some. We actually follow up normally every 6 months, sometimes 1 year, but we already have kind of 3 years data. Sometimes actually only one data is abnormal, but other times it's all normal. So I think it is kind of unilateral ectasia, but sometimes we see only the TBI is actually abnormal. Yes, kind of various.
I think that's a right point to highlight. We need to see them for a longer duration.
Longer, yes, yes.
Before we label them as a
yes.
keratoconus or no keratoconus.
Yes,
Thank
yes.
you.
Thank you.
Prema ma'am, can we have your talk, please?
So am I visible and audible?
Yes, ma'am.
First of all, thank you to the organizers of from Oculus for arranging this, and thank you to All India Ophthalmic Society for having me with you.
Ma'am, can we put it on slideshow?
Yes, I think.
Yes.
The chronology of events that ultimately lead to keratoconus begin with ultrastructural changes in the cornea and biomechanical processes that degrade the corneal biomechanics. And it is this instability which goes on to cause alterations in corneal shape and optical aberrations, which produce the severe visual impairment and degraded image quality in these patients. And when complications occur, they set the stage for a corneal transplant. So while the sequence of events has occurred in this fashion, the way we have diagnosed keratoconus has gone in exactly the reverse direction. Initially, it was only restricted to a slit lamp examination, waiting for patients' refraction and symptoms, until topographers and aberrometers allowed us to begin to diagnose them at the preclinical stage. It's only in the recent years that we have access to taking a peek into where the story actually began. The terms that are used to describe material properties can be very confusing. But the one that bears the greatest relevance for ocular tissue is probably elasticity. And with specific reference to the cornea, it takes a little twist and introduces some other parameters of viscosity. The biomechanical properties reflect the histology of the tissue. So it is the collagen fibers which give it the elasticity and strength. The differential distribution and orientation of these fibrils explains the anisometry. The ground substance gives it the viscosity, and the variegated components of the stroma give it a heterogeneity. But there is a third element which is often not referred to, often not spoken about, but which has an important and complicated influence on corneal biomechanics, and that is hydration of the stroma. So corneal biomechanics cannot be described in any one word, nor can it be measured in any one fashion. In fact, there are many ways of measuring corneal biomechanical properties, depending on the nature and the direction of the stress and the strain. And in a tissue like the cornea, which has uniquely non-linear biomechanics, you have additional modulus like the tangent modulus and the secant modulus which come into play. And I'll be referring to the tangent modulus subsequently. So what we measure in the cornea really depends on why we want to measure it. In the example of keratoconus, we know that it is a focal loss of elasticity which causes the corneal softening, allowing the cornea to deform. So it is the stiffness of the cornea which is going to determine how much or how little that deformation is going to happen. In other words, it is the resistance to deformation which can be explained by the term stiffness. And the elastic modulus is a measure of that stiffness, except that when we talk of non-linear tissues like the cornea, it is the tangent modulus which applies. The equilibrium between the mechanical stiffness and in this case the intraocular pressure, as we just heard from the previous speaker, to a large extent determines the corneal shape. And the mechanical stiffness is comprised of material properties, which we just talked about, and geometric parameters, including curvature, diameter, but most predominantly the corneal thickness. These geometric parameters have a bidirectional interaction with mechanical stiffness of the cornea. It is these three entities which have a very interactive and interdependent relationship: the corneal thickness, biomechanics, and intraocular pressure. And this was beautifully explained by Cynthia Roberts and explains why intraocular pressure measurement is often erroneous in eyes which have an altered biomechanics or altered corneal thickness. The relationship in particular between biomechanics and intraocular pressure is almost inseparable. So while the effect of these three entities has a compounding effect on the ultimate corneal behavior, they also have a confounding effect on the measurement. And this has been the biggest stumbling block in corneal biomechanics. How to separate one from the other, because each not only influences the other, but also affects the measurement of the other. And Cynthia Roberts and her team have introduced two new parameters known as the stiffness parameters, simply because they do exactly that. They measure stiffness of the cornea. And they are pressure-based parameters, which are based on what's known as the resultant pressure. We happened to do a study which confirmed that the stiffness parameter A1, which is the stiffness parameter at the first applanation, has a very high predictive accuracy in being able to differentiate normal eyes from keratoconic eyes. However, it does still retain that strong correlation both with intraocular pressure and corneal thickness. So, the same study, we also looked at the other individual dynamic corneal response parameters, as well as the combined and the newer parameters like the CBI and the TBI. And in summary, what we found was that the TBI had the weakest relationship with corneal thickness and biomechanical IOP, which makes it the most robust of all these parameters to be able to distinguish normal from abnormal eyes. The important finding that we had was that our study validated the claim that the biomechanic intraocular pressure, in fact, does not correlate with CCT. And this was the very purpose of developing the BIOP. The next logical step was continued by Professor El-Sheikh Ahmed, who was primarily responsible for the BIOP. When they, after having separated corneal thickness from intraocular pressure, we now needed a biomechanical parameter which is separated from intraocular pressure and corneal thickness. And they used the same finite element analysis with the numerical models to simulate both intraocular pressure and the air path pressure of the corpus, and fed in a whole spectrum of topographies and thickness profiles and corneal responses to come up with an algorithm which would be able to predict the corneal behavior, and validated that against a clinical data set as well as ex vivo measurements that they had done. So it generated these stress strain curves which correlated with age. And they found that the SSI, the stress strain index, for patients with the age of 50 was 1. So using that as the reference point, the SSIs, which the curves which swung to the left had an SSI of greater than 1 and represented stiffer corneas, while the curves that shifted to the right had an SSI of less than 1 and represented softer corneas. But importantly, it had a direct relationship with the tangent modulus. So the stress strain index then is a true biomechanical parameter, not an indirect one. It is a true measure of material stiffness. And most importantly, it established a separate independence from intraocular pressure and corneal thickness. And here lies its biggest advantage. It does correlate with age, and the studies that were done earlier had it validated both in a clinical scenario as well as in ex vivo cadaver eyes. Let me show you with a few examples how we have found it useful in our clinics. First, just to show you how it is in consonance with what we are already using or generally referred to define progression. Although there is no specific validated definition of progression, we generally rely on refractive stability. We look at the anterior tangential difference maps, the posterior elevation, changes in pachymetry, and the ABCD. Now we found that the SSI also shows, is in consonance with all that we are already using. And here was a pediatric patient whom we saw 4 months after the baseline. And the difference map seemed to suggest that there is a little whiff of a progression. Although there was no change in the pachymetry, there's hardly a 1.2 diopter increase right in the center, just a touch of it perhaps, but not very convincing. The posterior elevation also showed a 12 micron, which is falls short of what we normally take as the cutoff to define a progression. But the SSI map definitely showed a softening of the cornea, which meant that the SSI picked up this softening, or picked up a progression of the disease even before the shape changes were registered. So this gives us a window of opportunity to treat these patients earlier than having to wait for shape changes to occur, which may be important in certain situations. Yet another case, which was seen 11 months after cross-linking, and the SSI showed no change. This SPA1 showed no change. So did this mean that the cross-linking did nothing to this patient? We followed up this patient and with a 3-year follow-up. The SSI showed a definite softening, which suggested that this was a case of failure of the cross-linking. The apparent contradiction of this stiffness parameter showing a stiffer cornea is because the intraocular pressure was higher. And remember, we mentioned that the stiffness parameter is still entrapped in that tripartite relationship of corneal thickness, intraocular pressure, and biomechanics. So since it's not able to get out of that triangle, it registered a stiffness, but in fact the SSI, which is free of, independent of both corneal thickness and IOP, showed a definite softening. And just another case where we saw this patient 2 months after a cross-linking, and the difference map had this little area of steepening in the anterior curvature maps, which was suggestive of possibly a failure again of the cross-linking, or perhaps it was just an epithelial hyperplasia. The SSI, however, was very reassuring when it showed a definite stiffening of the cornea. And this was confirmed when the patient came back 7 months later, and that little patch of hyperplasia, a little patch of steepening on the cornea had now regressed and had flattened up. So in hindsight, it was indeed an epithelial hyperplasia and not a failure of treatment. So the SSI does have several advantages. It is a non-invasive measurement of a true biomechanical parameter, but its primary advantage is that it is independent of intraocular pressure and geometric parameters. It is not affected by contact lens wear, so you don't need to tell the patient to stop contact lenses 2 weeks before they come. And unlike the other pentagram parameter, the tomographic parameters, including the TBI and BAD-T, the SSI is applicable even to eyes post corneal surgery, again because it is independent of corneal geometric changes. However, it is important to remember that it was not meant to be a diagnostic tool, and its applications are restricted to the disease model that was used. And this is true of any algorithm that is created from finite element analysis. So for instance, the SSI, which was created from parameters of Keratoconus, would not apply perhaps to a pellucid marginal degeneration, for instance. It also does not map the location of the disease. It is a global response, just like the corpus is, but I suspect that that is where the future is heading towards. So as you could make out from the few examples that I gave, the clinical applications include the ability to track a progression of ectasias and allow the patient to enjoy a timely intervention, which may be important, especially in pediatric cases and cases where the corneal thickness is again borderline. It allows us to monitor the response to cross-linking and to detect a failure of cross-linking even before shape changes occur, and is able to distinguish biomechanical changes from topographic artifacts like we just saw in that patient with an epithelial hyperplasia. It might allow an early detection of iatrogenic ectasia if we follow our patients who've had refractive surgery. And in centers where orthokeratology is practiced, I suspect it will have a very useful input as well. Thank you very much, and thank you again to AIOS and to Oculus for having me on this webinar, which I truly enjoy. Thank you.
Thank you so much. Ma'am, you so nicely explained such a difficult topic on biomechanics with examples, and I'm sure everybody would have really benefited from this. I now request Dr. Rohit Shetty to give his talk on clinical applications of tomography and biomechanics in the new normal. Anybody wants to ask anything amongst the panelists?
Can I start, ma'am?
Yeah.
Thank you, Namrata ma'am, AIOS, Dr. Maipal sir, and Dr. Rajesh Sinha sir, and all the panelists for this wonderful opportunity to share work on application of tomography and biomechanics. My job is made easier because both Dr. Prema and ma'am and Dr. Suzuka have explained the whole science behind it. So I'm going to talk a little different today, and I'm going to see about basically this is the second meeting of biomechanics that just shows that the amount of interest it's generated. There are a lot of controversies and a lot of questions at the end of every meeting, and this is what we had last time. These are my financial interests. I don't think it has got anything to do with my presentation today. So one of the major challenges when we have biomechanics is, especially when you, ma'am, spoke about the SSIs and all these parameters, is there are four types of it. You have multiple permutation. One is everything is normal. Then the second group is your CBI is normal and your TBI is suspicious, a bad D is normal. Sometimes your CBI is normal, your TBI is abnormal. And so basically this is what makes people believe that, well, there is no science here. And a lot of people, clinicians think that, there's no need to use this because it's not giving you anything. But both the previous speakers, both Professor Suzuka and Prema ma'am spoke about, there's a tremendous amount of mathematical modeling science here. So my job today is to try to take some cases. What makes these cases completely unusual? And what are these when we need to look at? And what is the real missing link? So we started looking at the real truth. Where is it really leading to? So what I did was, instead of just sticking to just the biomechanics and the mathematical thing, I looked at multiple domain. One of the first thing which is very important when to understand the whole biomechanics and what the measurement is, to try to understand a little bit of epithelium. And these are some of our papers where we spoke about how epithelium can actually unmask your cornea. I'll let you know in a minute why epithelium understanding is very important in your understanding of your biomechanics, because that will give us an idea why some of your measurements sometimes don't match the way we want. And this is exactly what I said, because epithelium is here and this is your stroma, and your biomechanics is actually measuring the stroma, not the epithelium. So how does epithelium change? Let's look at this patient. This is a suspicious topography, and you can see that the topographies are suspicious, but your indices are normal. And this is where the challenge comes. You have a posterior elevation, anterior elevation here, not much here, but your bad Ds are all normal. Your whole enhanced Bellin is normal. Now, what do you do with this? Now, the question is, a lot of people would say, well, this is where people stop believing in biomechanics. They said, well, you know what? Topography is abnormal. The bad D is showing abnormality out here close to, then that means it does not fit my pattern. Now, let's play a devil's advocate. Who is right? The topography is right or the biomechanics is right? You can see that both the biomechanics and TBI are normal. So it's Now, so let's see what happens. This is what is very important. This is the elevation map which your bad D is picking up, and this is your epithelial map which is increased here. So the patient has actually, madam said, a near normal. Anything more close to 1 is normal. So the patient is got a normal topography, sorry, abnormal looking topography, which is actually created by the epithelium. And biomechanics is actually telling you the truth. If there was no biomechanics in this patient, probably what I would have done is I probably would have not done, not always people do. I do epithelial mapping, but it's not accessible to everybody. And you can see that epithelial thickness is high exactly in that zone. So this may be a person who may be sleeping with his eyes open, or he may be an exposure. But this case classically explains that the biomechanics was more stronger in explaining that this was a normal eye and not a keratoconic or not a form frustic keratoconic eye. Exactly the same thing. The bad D is abnormal here, but the CBI and TBI are both normal. And look at the epithelium. It's completely thick. And this, look at this area, is thicker. So that means that even though the topography can look okay, suspicious, sometimes your biomechanics actually can pick it up. And we had to look at the true picture. This is one of my patients. This is a very important case to show how biomechanics is important. This was in 2010. And that time we did not have Corvus. I had the ORA then 2009. So I've been seeing this patient continuously. He's a pilot, so I did not want to do a cross-linking on him. He's been stable, both the eyes. But I have the serial report. But what happens is the left eye is also right, both eyes stable. But because of this lockdown, he's completely indoors now because there's no planes which are flying and everybody is indoor. And look at this. This is the whole area of steepening. Now, his job is at stake. Do I go operate on him? If I operate on him, he can never fly again because he will have a cornea scarring, then keratoconus. This was a unilateral KC, which is maybe turning on to be a KC. Now, if I had only this, then I would probably have been a little suspicious. But here, I did confocal on him for 11 years. It's a very long time, serially. You see how the nerves are changing, and you can see that the right eye is perfectly normal. You can see the nerves. The left eye, what I'm circling are the dendritic cells. Dendritic cells comes when you have dry eye, when you have ocular surface inflammation. And the fantastic part of this case is I had 11 years of confocal microscopically serially done. So he is actually showing signs of a dry eye and ocular surface disease. And what has happened is because of the disease, see this, the patient, this was his 2019 and this is 2020, and the epithelium has become thicker. It is epithelial hyperplasia, which matches to what is happening here. So his biomechanics and exact same thing, you can see this whole donut shape, because when you have a very poor ocular surface, the first thing which gets affected is your epithelium. And when the epithelium gets affected, the corneal curvature changes. So what really happened was in this patient, we had his biomechanics because of some shuffling of slide, and the biomechanics from 2014 to 2020 has never changed. We did not have exercise then. That means it was stable. That means that the biomechanics never changed. The cornea looked like progression. But here, what I did was I did not start him on a cross-linking. I just gave him lubricants and restasis because my confocal also showed that there is a hell of a lot of inflammation out here, which is actually creating the problem. So what is important here in this case is your PBI and CBI were normal. Your SSIs can be normal, and your indices and the bad D is abnormal, but you have an inferior steepening, but your SSI is also coming to normal. This patient is not a keratoconic patient. This patient has something to do with inflammation or epithelial remodeling, and it's nothing to do with the progression. So it is very important that we look at this. And this is a classic example why people get confused with biomechanics machine, because they say, okay, if I did not look into all these things, I would have said that I don't believe in biomechanics because this looks like a keratoconus, but this is normal. And that's it. But you know what? This is normal because this is nothing to do with the cornea and stroma. It's to do with the epithelium. And we did run some AI modeling on it, and we have some, and AI also showed that this is healthy, and it said that it's not a keratoconic picture. And this is exactly the same thing, how epithelium can play a role. The second way of looking at it is we wanted to prove whether we are seeing is true or false. So we built our own custom-made polarization sensitivity, which looks at collagen, and this is how a collagen picture is. And this is the central collagen, this is a peripheral collagen. So we started looking at different types of collagen. When you have a normal biomechanics, this is how it looks. When you have TBI is more sensitive. I agree with Professor Suzuka here, because when we looked at the collagen imaging, you can see there's a dropout of collagen, and the CBI was completely normal here. That means that the collagen is showing some change. This is again one patient. When you look at this looks like a keratoconic picture, and you feel that this is a keratoconic eye. This patient had come to us with the progressive loss of vision. But look at this, CBI is normal, TBI is normal. Now, somebody would look at this and say, well, this is not true because this looks keratoconic, and look at the SSI is high. And what was abnormal is epithelium again. And what's interesting is this patient had a microneuroma on that. And this microneuroma was actually creating epithelial irregularity, and the PSOCT was normal. And again, some cases where epithelium is normal, this how the whole map is being structured by changes happening on your epithelium and the stromal surgeries. So we wanted to do one more thing. We wanted to see whatever we are seeing, are we really seeing? Because each and everything, like Prema ma'am spoke and Professor Suzuka spoke, that you're looking at stress and strain, you're looking at collagen, but you are not measuring or seeing collagen. Of course, polarization OCT is one of the ways. We wanted to see, can we real time look at the collagen, image the collagen? The only time we could do is when you're doing a smile surgery, because you have a smile patient, you do a biomechanics, and the same patient's corneal tissue are going to take it out, and we can actually image the collagen in your lab. And this is what we did. These were the patients on whom we did the smile extras. And you can see them changes happening. And we started taking the collagen, and then we started looking at the real picture. So what we did with mix of biomechanics and both the cellular biology, we were very keen on doing it because that's the only time we could prove what we are seeing. Because in the past, we looked at lysyl oxidase as one of the culprits. And this is a patient where we had imaged it. We did the smile extra because all of them are on the suspicious zone. And we took the lenticules. We had already imaged the collagen here. And this is very interesting. When you have a poor biomechanics in this patient, the collagen is what was abnormal, and the lysyl oxidase which binds it was normal compared to the second one. And that's why your smile extra worked beautifully in this patient. And you can see that what ma'am showed, when you do an extra, you can see the changes happening from softer to stiffer. And this shows that your eye is actually getting better. And this is a patient who had a weaker SSI to begin with. And you can see that the patient had a poor biomechanics. And this is where I wanted to see what is really happening, and what we really, this was a smile surgery. And what we found here is that the collagen was low. So when you see that the collagen is low, it actually matches with your biomechanical changes. Basically, what I'm trying to say is we are trying to match with exactly what the machine is showing to what actually the patient has. I mean, it's a little difficult to explain it in a short time, but it's basically trying to mix the cellular versus the molecular signatures. And again, when you do on these corneas, you can see the change after the extra, the smile extra, and you can see that it's becoming much stiffer. So this is a complete picture. So that what many times when we look at it from one angle, sometimes we miss the picture, and we have to probably see it from multiple directions. And two things which really helped is, there are different ways of analyzing this. This is one of the ways. I'll skip these slides. A new prototype of Corvus is coming, which looks at multi-zone. It's not just one zone. You're trying to look at multiple zones of, you can look at the top, center, and down. So you can get deformation values from different zones. So what I'm trying to say in this is biomechanics is a very integral part of a refractive surgery. It is complex. Sometimes as simple as an epithelium or a dry eye can mess up your understanding of it, because you don't see what you don't always see what you want to see. And because you'll have to put a little bit of an effort. So the cases I showed in the last few minutes is exactly what we should be looking at when you have those confusion. And looking at combination of biomechanics and topography, I think is the next new normal in the near future. And all I showed was to prove that when you integrate, I mean, it's just for research. We don't need to use all this to prove that the biomechanical measurements were actually telling you the truth, even though the topography or tomography was sometimes not telling you everything. So to prove that, I used the molecular signatures to prove that the molecular signatures which had low collagen or low lysyl oxidase actually showed as poor biomechanics. The future is Brouillon or differential Corvus, we call it. We don't have a name. I'm using one of the prototype. I work with Oculus on this, where we're looking at Corvus at different zones, and we're just collecting data. Hopefully it should come out in the future. I thank you again for this wonderful opportunity to present our data.
Thank you, Rohit. I think every time we listen to your lecture, it has, one more new addition to it. So it becomes, like fourth edition, fifth edition. So thank you for, correlating everything that you see on the machine, automated fashion, to the molecular signature, to translating it at the cellular level, and to understand, the correlation of the machine with the actual thing. And proven by, of course, the markers, the markers that you're studying, and the collagen itself. Anybody would want to ask anything? Sir, would you?
Just one query, Rohit. Wonderful presentation as usual. You talked about smile extra and smile cases where you looked into this thing. Did you check into the biomechanical changes happening in these two categories, smile extra versus no extra,
Yes,
and correlating that to a clinical outcome?
yes, sir. Thank you, sir. Two things we did. Like Prema ma'am said in the beginning, of all the biomechanical parameters, the closest one which was giving us good results was the SSI parameter.
Okay.
We did a study where we did one eye extra and other one, and the patient had the same biomechanics, and they had the same collagen imaging, virtually everything. And we found that the extra eyes, the collagen imaging we did on the polarization OCT was completely something closer to a normal eye compared to the other eye where we did not do an extra one. And the second was the SSIs, the stress strain index definitely showed it to become stiffer. And we did it after a month when steroids have stopped and there was really no effect of intraocular pressure also, because many times this could also have impact on this. So we waited for at least 6 weeks, I think, to check for the exercise.
Okay.
Actually, I have a questions for Dr. Mohit Shetty. Actually, we mentioned about the Smile Extra. So do you think, actually, I also attempt Smile Extra in my practice, but sometimes there are some corneal haze developed. Do you think that actually it is because of the it means it is stronger because of the extra collagen connection within the cornea, or is it just an information? Because sometimes I find that some of the corneal haze actually will decrease the rate of recovery. The unaided vision may seems to get better slower than people with simple smile alone. So do you observe these kind of observations?
We do. I've worked on it. What happens is we did some work on confocal microscopy on them. You get more inflammation when you have patient with more ocular surface issues.
Mm-hmm.
So if you go back and look at your data of patients who had haze, you will see that they had more dry eye, or they have a contact lens intolerant patients. Because what happens is when you have a contact lens intolerant or a dry eye, your cornea structurally, anteriorly, has got more inflammation in it. I showed some slides of dendritic cells. So when you put your riboflavin into it and you do a UV light, cells behave extremely aggressively.
Oh.
And the wound healing of those cells is at least 30 times different than a wound healing in a. How did we get the 30? Because we did some experiment where we looked at inflammation on these corneas versus normal. I mean, it was an in vitro experiment, not in vivo. But that's the reason if you're doing an extra, you have to first look for the OSDI scoring, if you're contact lens intolerant, or if you have a dry eye. If you have these three things, extra will have, or if you can do the extra, but you probably have to go deeper on your cap if you have a thicker cap instead of a thinner cap, so that you bypass the corneal nerves. And you have to keep a stronger steroids, and you have to keep it for at least 8 to 9 weeks.
I see. Thank you for sharing.
What is the longest follow-up that you have on Smile Extra? And what is the relationship of the biomechanics as regards time in patients of Smile Extra versus the other eye?
Sir, longest is 2.5, 3 years. But
Okay.
unfortunately, the SSI parameter has come recently. So the
Mhm.
longest follow-up I have is 1 year, sir, 9 months, 9 to 10 months.
And what
And
is the relationship over time?
the eye which there are some which does not show change, but majority of them, the eye where you have done an extra definitely has it shows SSI from a softer to a stiffer mode. And that is one thing. And the second is we are following it up with the polarization OCT, which looks at the collagen fibrils. The fibrils are much more organized. It could be scar, it could be just a more organized nature compared to the other eye where we did not do an extra.
No, but does it last?
As far as the imaging is concerned, till 1 year, it's holding on.
Gone in 1 year?
Yes, sir. It's
Yes.
holding on, sir. Holding on.
Holding on, okay.
Holding on.
Okay. So that means that but are there any parameters which are showing that there is a decay or
No, sir, not at present.
not at present?
The
Okay.
best parameter, sir, is imaging the collagen itself at that level, the interface level. The collagen is looking exactly the same as it was on the first month.
Okay.
So maybe 3 or 4 years later, when there's a new turnover of collagen, we don't know. But at least at this point of time, it's holding on. But like Dr. Tommy said, if you have more dryness or if your patient is contact lens intolerant patient, then you will have a different type of reaction. You'll have more haze there.
Any effect on the refractive outcomes? Any nomogram adjustments that you need to do, or really nothing?
Sir, if you are doing it on a very thinner, small power, a lot of us would not do it. We do a PRK, like a -2 or something. Then it changes the epithelium by around 8 to 9 microns, sir. It
Okay.
makes the epithelium thicker.
Uh-huh.
So a lot of these patients, so when you're doing a higher power, that 8 to 9 microns doesn't make much difference because patients accommodates and you don't have an issue. But if you're treating a 1.5 or 2 diopters or less, then it is best to keep a little bit of, sometimes it makes the patient change the epithelium a bit. So we have to be little careful on, I mean, either way, you may sometimes, it goes on a hyperopic side, sometimes it goes on a myopic side, means under correction.
So, but you were saying this, but this you're saying regards PRK. I'm talking about Smile Extra.
Smile Extra only, sir.
Smile Extra only. Okay.
And likewise for LASIK extra also.
Ma'am, LASIK Extra, we tried doing all the thing, but it doesn't show
Didn't
it.
work out.
It doesn't. That's because I think you already made it so weaker that the change doesn't make a big effect on it. But the most important take-home point, which Sir Tityal sir had asked last time, is that it's very confusing. Sometimes each value is behaving differently. I feel there is a huge factor of epithelium also, sir, because that is why your topography is being unmasked or masked by. But in fact, I feel the biomechanics is actually telling you more truth than the topography.
But epithelial hyperplasia is something which you cannot control. I mean, you cannot redirect, you cannot control. It will happen the way it will happen. So I think you have to live with it. I mean, even though you may say epithelial hyperplasia is responsible for this, but you can do little about it.
No, ma'am, what I said was if there is hyperthelial hyperplasia and you know that cornea is normal, even though the topography looks abnormal, we can give them an option of one or the other surgery, even ICL or something.
Something else.
Sometimes some of these cornea look just like a keratoconic cornea, and many times we feel like we have to do a collagen cross-linking or a PRK or something. Like I showed that patient, it was not a progression, it was actually a pseudo progression, where the biomechanics was actually showing stability and the topography was showing progression. But the issue was with the epithelium there.
How many of such cases you would have gone ahead and done a surgery?
With the more understanding of
Yeah,
this,
where you've unmasked this kind of a thing and then, you
then
know,
I
change.
would see, I would not, I mean, still I would not jump and do a LASIK on them, but I have done PRKs on them or
Okay.
given them a choice of ICL. Otherwise, we would wait for 2 years for it to see whether it's progressing or not. And some of them have remained stable, not LASIK definitely.
Okay, so now we have a sponsor's duty to perform, and so this is the video of the same. And I will be now talking. Wait, I'll be talking to you about application and reliability of Corvus ST in clinical scenarios, which includes cases which are, you know, beyond keratoconus. Some of them with keratoconus as well as refractive surgeries. So we'll be going through these case scenarios, and this we've already learned from the previous talks that whenever you have a softer cornea, the applanation length, the arc length, the stiffness parameters would decrease, and so would the ARTH. Now, this is just to show a frank case of keratoconus, which on pentachem shows that the BAD is abnormal, and likewise on the biomechanics as well. When you see the TBI, the CBI as well as the BAD on the biomechanics map, and this is a same patient. One eye has got mild keratoconus, the other eye has got severe keratoconus, which can be highlighted. And on this dynamic corneal response curve, again, you can see that the various parameters are also altered, like the applanation length, the arc length, the DA ratio, and because it's mild, the values are altered less here as compared to severe keratoconus, where they are altered more if you compare the two fellow eyes of the same patient. Now, if you look at the CBI, TBI, and the BAT, then one realizes that these biomechanics are good for the cases which are mild, or for the cases which are subclinical, or for the cases which are form first. But when it comes to the grades of severity as to moderate or severe, it's not able to distinguish between them, because beyond a particular value, it does not increase. So it is, although the grades of keratoconus in terms of severity are so different in both the fellow eyes, but the values of TBI and the TBI and the CBI would be, you know, nearly the same. Only the BAD is the one which is higher in this eye because of a more severe keratoconus. So this is just to show the deformation maps of the same, and then again you can see that in mild keratoconus the deformation will be much less, because it's a stiffer cornea as compared to severe keratoconus, where the deformation will be much more. Now, this is just to show a case of vernal keratoconjunctivitis, which had pachymetry, which was good, almost to the tune of 550 microns. Keratometry also, which was good. The BAD is also normal. But if you look at the biomechanics, the biomechanics are falling in the range of a suspicious category, 0.38, and then TBI of 0.35. So these cases actually have to follow up over a period of time, and especially when it's a child, then you know that you have to follow up these cases over a prolonged period of time because they may have keratoconus ectasia. Now, this is yet another case of vernal keratoconjunctivitis only, and here notice that keratometry Kmax is about ranging from 42 to 45.8, and the pachymetry is also to the tune of 512, which is borderline. But these cases, they need to be followed up because the CBI and the TBI, they are all falling in the suspicious category. So these are and this is a child. So we need to follow up these cases on the biomechanical parameter as well. Now, this is just to show a case of pediatric keratoconus, which is symmetrical in the right eye and in the left eye, both of them. It is so symmetrical that the maps also look absolutely symmetrical. And again, if you look at the D values, they are also symmetrical, 6.3 and 6.31 and 30 here. And if you look at the CBI and the TBI, they also are so symmetrical. So in very severe cases, I think biomechanics is something that has to evolve and that has to go into further research. The manufacturers will have to, titrate their readings for more severe cases as per the machine, as far as the machines are concerned. Now, this is a case of PRK, where a case where PRK was done, and as you do the PRK, notice that the cornea becomes flatter. The pachymetry also decreases, and the anterior curvature maps change. The posterior corneal elevation maps, they remain same in the pre and the post-operative period. And if you look at the dynamic corneal response in these cases, again, notice that there is a decrease in the deformation amplitude to some degree, and the applanation length also decreases to some degree. And this is in the post-op period of PRK, and the CBI after the laser vision correction, which the machine detects, is 0.0, which is in the normal range, which means that the PRK does not really alter it too much. And if you see the pre and the post-op picture of a PRK, then again, this highlights the fact that the cornea is not that much altered, and it doesn't become very soft after PRK. On the other hand, if you look at the LASIK maps, again in this, the maps, you can see that the cornea becomes flatter. The posterior, the pachymetry also decreases. The posterior back elevation remains almost the same, and the anterior elevation is the one which changes. And again, if you look at the post-op picture here, the CBI, LVC, the biomechanical tomographic assessment will show that the CBI is 0.0 in this case. And if you look at the DCR again, notice that the applanation length would get altered, and so would all these parameters, as is expected after the LASIK surgery. Now, this is a case of post-LASIK ectasia, and in this case, as expected, the D value is altered, and so are the other parameters on a dynamic corneal response. And this is a case of SMILE, pre-op and post-op, where again the anterior part of the cornea is the one which has gone alteration. The posterior one has not got any alterations. And again, if you look at the CBI and the TBI, the pre-op is 0.35 and 0.01, and post-operatively the CBI is 0.07. So the SMILE really doesn't alter it too much, although it does alter it slightly, as is seen in these parameters of arc length, DA ratio, as well as the inverse concave radius ratio. And if you look at on the video images, again the response of the surgery is not that perceptible, because if you compare it with LASIK, then of course it is much better in terms of the corneal biomechanics. Now, this is a case of post-LASIK ectasia for which intacs and collagen cross-linking has been done. And if you look at the densitometry values, and this has been reported by Dr. Ambrosio, that these values, when you do a collagen cross-linking, would increase. So here it is 29 and it has increased to 31. So this is expected, especially in those cases where collagen cross-linking has been done. And this area of flattening, this blue area has increased and this yellow area has decreased, and this was the only change that was seen post-operatively after 1 month in this case. So again, this is to show the CBI values, which are showing 0.0. And I think again, in such cases, the machine needs to, also need to know how these cases are going to be read, because these are complex surgeries or multiple surgeries. Now, we also wanted to see our corneal transplantation cases. So this is just to show where the sutures are intact in an operated case of penetrating keratoplasty. Notice that there is no ectasia at all present, but this is a case of keratoplasty where sutures are out and the peripheral part of the graft is looking ectatic. Again, the D value is 1.7, and here, of course, the D value is very much increased because of the ectasia part. And if you again look at the CBI and the TBI values, they are again showing that it is very much increased in the case where ectasia is present. We also looked at our cases of DSEC, and in this we could not find anything perceptible except for the fact that the corneal thickness is increased, which is expected in this case. And again, I think it is important that the biomechanics of not only the host cornea, but biomechanics of the donor cornea should also be studied, which includes the DSEC as well as the DMEC. And that is something again where the manufacturer needs to work on the Pentachem machine and the Corvus machine, because as of now we are not geared to study cases of corneal transplantation, whether they are sutured or whether they are sutureless. So this is again a post DSEC case. It doesn't give you anything much except for the fact that CBI is 0.84 and TBI is 0.56, but the corneal thickness is increased. So one doesn't know how to actually correlate these values with a double cornea that such cases generally have. So to conclude, the standardization of the normative data in different ethnic groups is required, and I think it is going on in different geographical locations because these would be different. The limits of the diagnosis of the study of biomechanics need to be expanded beyond palm-first keratoconus, subclinical keratoconus, and early keratoconus. And it should be more inclusive to include cases of other disease pathologies, including corneal transplants as well as donor corneas. And I think we are still in the stage of infancy, but there's a potential to change the whole new world of biomechanics as we get smarter and smarter into it. I would like to acknowledge Professor J.S. Tityal, Dr. Rahul Bafna, and the staff of the LASIK lab for helping me with this presentation. Thank you very much for your kind attention. So, any thoughts on it, Rohit?
Oh, hi. Can I have a question? Can I ask a question? Okay,
Yes,
so Professor Namrata, so I believe you gave a treatment for VKC vulnar conjunctivitis patient. VKC patient. Yes. So I'm wondering if there is a effect from the VKC treatment on biomechanics. Is there any change in the biomechanics parameters?
So that is something that we are looking at, and we have not yet analyzed the data. There's a whole thesis going on this, and as and when we analyze it, we'll definitely tell you. But I can tell you on a previous thesis that we did, which was on ocular response analyzer, not on Corvus. So when the inflammation was treated in those cases of active vernal keratoconjunctivitis, and there were 60 such eyes on ORA, there the parameters did become better as compared to as compared to prior treatment. But on Corvus, we have not yet analyzed our data.
I have a question.
Thank you.
Oh, sure. Yeah.
Please, no
Go ahead.
problem.
Oh, okay, so I have a question. So actually, how you find the repeatability of the Corvus in children compared to in adults? Because, for example, I saw you have done a couple of kids with vernal keratoconjunctivitis. So how do you feel about the repeatability of the biomechanical measurement in these cases?
So pediatric cases, we've not done too many. We've done maybe about 10 or 12 of them. And repeatability, of course, cooperation is a major factor in these patients. And I don't know how the biomechanics behave also. I was trying to look at a paper also in pediatric keratoconic eyes or even pediatric normal eyes, whether there's any data. There's none that exists. And this we were evaluating because we gave a thesis on pediatric keratoconus and we wanted to do corvis on those cases if it was possible to do it. So we have, as of now, only data of about 10 eyes of pediatric keratoconus. We do not have more than that.
Yeah, because in my impression that some of my colleagues using the corpus, they told me, oh, it seems a little bit unreliable because sometimes I think it requires a lot of techniques and patient cooperation, because even in adults, sometimes my colleagues told me that, oh, I can't find a very reliable data. Have anyone observed this kind of observation, or is it there is some like particular techniques that we can improve the repeatability of doing the corpus measurement?
One of the most important, sorry, ma'am.
No, Rohit, continue.
One of the most important thing we have noticed is if you are especially doing it for a study, the duration, the time when it was measured has to be maintained the same, because your intraocular pressure changes a lot. And because even if it changes by 2 millimeters of mercury, the biomechanical stiffness changes, especially with the PBI and the CBIs. And so sometimes if you do it at the end, somebody has he's walked for a long time, everything which increases your IOP would have an effect on it. So it is very important to measure the time of biomechanical test done. And the second thing is, ma'am asked, I think we have kind of slowly moving over to, like Prema ma'am said, the SSI parameter for your post-operative changes. I think it has because it's not affected by IOP much. So I think it has got much more strong robustness in it. For example, but I would like to ask ma'am about this, Dr. Prema about this. They say that anything above 1 is normal. But I'm seeing that most of, at least the Asian Indian eyes, what I'm seeing, even a healthy ones, very difficult to get a very above 1, the SSI index. Is it something which you're seeing also?
Yeah. Actually, Rohit, the SSI is very age dependent. The SSI of 1 was chosen for a 50-year-old. So an SSI of 0.7 could be normal for a younger patient. Or a SSI of 1.1 can be normal for a patient. Its value is more in assessing a comparative change than in an absolute value, because the absolute value will also will largely depend on his age and ethnicity and so many other things. So it's the change that is more significant.
So that's what I would like to tell Namrata ma'am, that when you're looking at SMILE or any of this process, probably you look at the change from an SSI. That would be a better measurement than a CBI or TBI, where we don't really have a parameters, nothing baseline determined for them.
Okay. So if there are no questions, Dr. Chitial is there, sir? So then we would move on to the next talk. And the next talk is going to be given by Dr. Tommy Chan.
Okay,
Dr. Tommy, can you share your screen, please?
So thank you. It's my honor to present with all the biomechanics or cornea expert here. And thank you for the AIOS and also the Oculus invitation for this presentation. So today I'm going to talk about the combined use of the corneal tomography and also dynamic response in refractive surgery screening. So right now I'm working in the Hong Kong Sanatorium and Hospital, which is the private hospital. And so I did a lot of refractive surgery there. So as we all know, every corneal ectasia is a nightmare. So we try to avoid it. And especially the aesthetic change can occur anytime after the surgery. And previous study have shown that abnormal preoperative tomography is the most significant factor with the highest relative risk. So we don't, for the keratoconus, it is actually a progressive non-inflammatory disorder resulting in corneal thinning and protrusion. And posterior cornea and pachymetric changes are often seen in the initial stage of the ectasia and present as the earliest, one of those few of the earliest tomographic signs. And the rotating Schoenfuchs imaging actually can provide very useful information on the basis of tomography data for diagnosing early keratoconus changes. And in here, so I will deviate a little bit and talk about a little bit of the topography. So this is the BAD that we all know. And for some of those who are new to the PanaCam, so the BAD actually will evaluate the elevation profile of the cornea, of the anterior surface of the cornea, and also the elevation profile of the posterior corneal surface of the cornea. And it will also evaluate the change in corneal thickness from the thinness point. And they will give us the various parameters, including giving you a final D values. And for the corneal topography, it actually used an enhanced best fit sphere instead of a usual best fit sphere that we know. So it will actually exclude the elevation point from the cornea in calculating the best fit sphere. So this increased the sensitivity of tomography in analyzing the cornea for any abnormal changes. And for the corneal thickness spatial profile, CTSP, so actually it measures the change of cornea from the thinness point, and it creates a circle, concentric circle centered around the thinness point of the cornea. And you can see there is they will plot against with a curve. And if there is any deviation from the curve, this may signify any abnormal changes of the cornea thickness. And as I mentioned, there are 5 various parameters of the PanaCam, and it will finally give you a total deviation value, the final D value. So it evaluates the deviation from the front part of the cornea, the back surface of the cornea, the pachymetric progressions, the thinness point, and also an ART max. So any values that is abnormal, it will appear suspicious, it will appear yellow in color, and any pathological finding will appear red in color. So as Professor Cole has mentioned about the Schoenfuchs keratoconus, so it actually is defined as a cornea that has low abnormal clinical and corneal topographical findings with the fellow eye of a clinical KC, because as previously shown, there is no true unilateral KC. So those seemingly abnormal eyes is a very good samples that we can try to evaluate. So previously we conduct a study, we find that the final values of BAD actually has an area under curve of 0.76 for detecting Schoenfuchs keratoconus. However, the sensitivity is only 53% with a specificity of 80%. So it is not that sensitive by simply using the BAD in evaluating the Schoenfuchs keratoconus. And as previously shown by talked by different experts today, so corneal biomechanical property actually can better represent the cornea problem, because it is actually the basis of keratoconus, which is the weakening of the cornea. So the Corvus actually is a high-speed Schoenfuchs imaging camera that are able to capture over more than 4,000 frames per second with a 8 millimeter horizontal coverage. And so previously we worked on a very early prototype of the Corvus, and we used 2 low parameter. At that time, we call it DA ratio 2 and DA ratio 1. And so we all now know that the DA ratio 2 is actually incorporated in the Vincent-Cruz report for the CBI. So and before that, actually, we tried to use the DA ratio 2 and DA ratio 1 and try to differentiate patient with normal compared to keratoconus. And we find that the area under curve is actually quite high, more than 0.93 and 94 here. And we find that a single parameter actually has a very good diagnostic ability in differentiating cornea from normal to keratoconus. And as I mentioned later on, the Biomechanical report actually used various parameters, including the DA ratio, which is actually the DA ratio 2, and generate a CBI for evaluating the cornea. And so this is the Biomechanical report. And so it used different corneal dynamic parameter, and it will give you different parameter like the DA ratio, the HC radius, the ARTH, and the stiffness parameter, and give you a CBI, the Corvus biomechanical index. And this picture was shown in also in Professor Cole's presentation. And actually, so you can see a soft cornea actually has a higher DA ratio and a higher integrated radius and lower ARTH and also the SPA1. And a previous study from Biomechanical groups actually showed that the CBI was able to detect keratoconus with an very high area under curve of 0.990. And in our study, we also find that we have an AUC of 0.971 of simply using the CBI in differentiating normal from keratoconus. And in the previous study, we tried to evaluate to differentiate from keratoconus from normal using the CBI and BAD, and we try to compare the diagnostic accuracy. And we actually find a comparable area under curve between the CBI with an AUC of 0.785 and the BAD with a AUC of 0.757 with no significant difference in detecting keratoconus. However, as I mentioned before, the sensitivity is not very optimal. It is actually a 63 and 53% when we want a 80% of specificity. So by simply using the CBI or BAD alone is not sufficient in detecting the Fox cases. And this is the ROC, the receiver operating curve of differentiating keratoconus from normal and differentiating from keratoconus with normal. You can see in this curve, the CBI and BAD has a very high AUC because, as you know, that it is a already clinical keratoconus. But in terms of the Fox keratoconus, you can see the sensitivity drops a lot, and so the area under curve reduces a lot. So we want to know the big picture because the big picture of a cornea actually, the topography is only representing the shape of it, and indeed, actually, the biomechanical property governs its shape. So therefore, we should evaluate the whole picture of the cornea when we want to evaluate if the cornea is normal or not. So in terms of screening for keratoconus, I believe that it is not the future. It's today that we should use the tomography and biomechanical response together. So in here is an example. You can see so a patient with a normal BAD but a abnormal CBI. We know that it will have an abnormal CBI. So simply evaluating the BAD alone may give a false negative result when we try to screen patient with keratoconus. So in this case, for example, you can see the CBI here and the BAD here, and you can finally give rise to a topographical biomechanical index, the TBI, which is a combined topography and biomechanical index. So this is an example. You can see a patient with a normal right eye but an abnormal left eye. So the right eye is a very good sample that we can try to evaluate. And you can see the BAD is normal for the right eye, but however, the CBI is abnormal because we believe that keratoconus is a bilateral disease. So inherently, that cornea actually should have some abnormal biomechanical properties. So we can detect it as Dr. Ohit had already mentioned. The CBI actually is representing the truth of the cornea instead. So we can see the TBI is actually quite elevated in this case. So in the Ambrosio group, in the first paper on the TBI, you can see this is the keratoconus with normal. The TBI, the black line here, has a very high, nearly 0.99 of area under curve in differentiating keratoconus from normal. But on the other hand, when you look at the foveal keratoconus to normal, you can see the CBI and also the BAD, which is here, is not very optimal, similar to what I report previously in our study. But the TBI also show a relatively good diagnostic acumen, the higher AUC in using TBI. And we actually conduct a study in the Chinese University of Hong Kong. All the patients are Chinese patients. And indeed, actually, keratoconus is more rare in Chinese, I think, compared to India or other South Asia countries. And we have a 41 keratoconus patient, 37 control, and 23 subclinical cases. And 1 eye of each patient was selected. And you can see for majority parameter, the keratoconus suspect, we call it suspect, are similar to the normal patient, except that the cornea is slightly thinner in those keratoconus suspect, but they are still all within a normal range in our group. Of course, compared to keratoconus, all the parameters are significantly different from normal patients. And you can see the TBI in our group find a very high 0.925 of AUC, and which show a very high specificity of 82% and sensitivity of 84%. Whereas compared to other corpus parameter, you can see except for the ARTH, all the other has an AUC under 0.80. And for the Pentacam also, all the parameter had an area under curve of less than 0.80. And you can see the sensitivity drops tremendously here, except for the ARTH. And for the area under curve, the graph here, you can see the AUC for the TBI is the black line and the BAD is the red line. You can see there's a better diagnostic capability of using the TBI, and this is the study we published in 2018. And so I will end my presentation with some example. So this is one of the patients come for refractive surgery, and seemingly the topography looks normal, except that the cornea is a bit thin in this case. So we have to be very careful for patients with very thin cornea. So in our Chinese population, majority of patients has around 550 micron, and any patient lower than 500 micron, we will be very cautious. But actually in the northern, some patients came to Hong Kong from northern part of China, and actually the normal cornea thickness is around 500. We don't know why, but maybe it's a genetic differences. And you can see the BAD here is relatively normal in this case. And however, when we try to do the CBI for this patient, you can see the DA ratio, the integrated radius, and the SBA1 are all elevated. And you can see the CBI is quite high. And the TBI, of course, will be high in this case. So in this case, I will actually advise the patient for observation instead of performing refractive surgery in this case. So this is another example. You can see a seemingly normal topography, and there's some yellow in color. So we always encounter some yellow in patient. It's very easy to when we saw a lot of red in a patient, then we can ask the patient not to do it, because it's very simple. All the color are red, and this means dangerous. But in this case, there are some yellow and some white parameters, so we have to be very careful. So in this case, we also do a CBI for this patient, and we find that a very relatively high CBI in this case, and of 0.93. So, and the TBI actually is 1.0. So in this case, I actually advise the patient not to have refractive surgery, and also the patient need to be followed regularly to look for any aesthetic changes in long run. And this another cases, also some yellow, and the yellow suspicious final D values, and also so as high CBI. And this case, the TBI is also high. So all these cases I want to show is that they are borderline cases, and sometimes we always encounter those cases with some suspicious value in the BAD. So it is actually the Corvus, the CBI is a very good diagnostic tool. Combined with the BAD give rise to TBI. It can actually give rise to a very good picture, as Dr. Vohishati had mentioned. It actually gives you a very true picture of the corneal biomechanics of the patient. So therefore, for the future of refractive surgery, we believe that we should combine the corneal tomography and biomechanical properties in order to provide a safer and more efficient refractive surgery screening. And thank you very much for your attention.
Thank you, Dr. Tommy Chan, for a very comprehensive and a wonderful presentation. And thank you for all your contributions. There's so many publications of biomechanics. Any questions anybody would want to ask?
Can I ask a question? Many times you see that the CBI shows that it is abnormal when your BAD-D and your TBIs are not. I think it's because it uses more of your corneal thickness parameter along with the biomechanics. And it happens especially in a lot of our Indian populations or Asian population when your cornea is on a thinner side. So I would like to ask you and Prema ma'am, how much weightage you give this case when your CBI is only abnormal and the other two are normal or near borderline. Sometimes, the TBI is completely normal. The BAD-D is still in green, but CBI is showing as red. And the corneal thickness is around 505 or 510. Is it because it's more related to the corneal thickness that it is skewing so much?
Yes, ma'am. Would you like to comment on it? And then Dr. Tityal, sir.
Yeah. In the study that we did, we found that the TBI had a higher accuracy as compared to the CBI. And probably one of the reasons is its independence from geometrical factors. So I would, between CBI and TBI, I would place more reliability on the TBI. So if the CBI was abnormal, but the TBI was normal, I would think that more likelihood of the cornea being normal.
And that is one of the reasons I think the Vinciguerra's team brought out this SSI index, the stress strain index. It is from the same group, I think, whose this SSI index is from.
Yeah, the SSI index was really Dr. Sheikh Ahmed, who did this after the success of the biomechanical IOP, where he could make the the IOP rid of the confounding influence of the corneal thickness. So the next step was to get a biomechanical parameter which was independent of intraocular pressure and corneal thickness. That was the evolution of the SSI.
Okay, thank you, ma'am. I think Sir, Professor Tityal, sir, would you like to say something?
Nothing much to add. I think explained very nicely by Dr. Prema. I think definitely TBI would be a more reliable indices because that will have both tomographic and other issues. So she's absolutely right. Rohit also correctly pointed out TBI will have a much better value. I agree to that.
Thank you, sir. And I would now request the last presentation to be given by Dr. Vaishal Kenia on role of Corvus ST, a biomechanical assessment tool in modern refractive surgery.
Am I audible, ma'am?
Yes.
Yeah.
Just put it on. Yeah, perfect.
One second.
You have to just put it on the slideshow. Yes.
Yeah.
Yes.
Okay. Good evening, everyone. And it was very gratifying to hear so many topics on corneal biomechanics and their views. And I thank AIOS organization and Oculus and KLB for giving me this opportunity to talk on the role of Corvus ST, a biomechanical assessment tool in modern refractive surgery. Refractive surgery is done, refractive screening is done to separate abnormal corneas from normal ones. In doubtful Belen-Embrasio displays, integrated Corvus pentacam helps as an adjunct to screen abnormal corneas. Corneas which is biomechanically strong is suitable for refractive surgeries. Cornea as is not a piece of plastic, as this phase was as said by Cynthia Roberts. Cornea is having both elastic and viscous properties. Elasticity describes the ability of a body to resume its normal shape after deformation. Viscosity describes the resistance against permanent deformation. And stiffness describes the force needed to elastically deform the body. Biomechanical changes precede topographical structural changes, and this is the very basis why the biomechanical tools have become more important in refractive surgery screening. We want to pick up the subclinical keratoconus, and picking up those cases would definitely prevent iatrogenic ectasia. So assessment of corneal biomechanics in vivo is still evolving, and ORA was the first tool where the CH and the CRF sensitivity and specificity was found to be very low to differentiate keratoconus from normal corneas. The Corvus ST, or the corneal visualization Schimflung technology, uses a real-time corneal deformation data to analyze the corneal biomechanics. It records the corneal reaction to a defined 30 milliseconds air puff, and this is a defined force which is used to deform the cornea. Unlike the previous generation ORA, the ultra high-speed Schimflung camera uses 4,300 frames per second to record the deformation or the corneal dynamic response. The Corvus ST is primarily used basically for optimizing ectasia detection, for biomechanical analysis pre and post LVC and cross-linking, for glaucoma screening, and it gives a BIOP, or the biomechanically corrected IOP. The Corvus ST essentially has the Vinci-Guerra screening display, the integrated display, and the comparative display. The Corvus biomechanical index is made up of 5 factors, parameters, and as Dr. Rohit pointed out, the embrasio relational thickness is one of the factors which is a non-biomechanical parameter, but incorporation of that was found to be negating the bias for thickness, and that's why it was found to be much better than the ACBI index. They had compared the CBI as well as the ACBI index, where the ACBI, the embrasio relational thickness, was removed. They found out the CBI index to be more sensitive and specific. So the CBI index is still holding good, and the embrasio relational thickness is still incorporated in. So Corvus biomechanical index is primarily used to differentiate normal corneas from keratoconus, and it's based on corneal thickness profile and deformation parameters. It's got a specificity of 98.4 and a sensitivity of 100%. So deformation amplitude, the softer corneas deform much quicker, much more deeper, and over a wider area than a stiffer cornea. And this has been the basis for deformation amplitude ratio, which is the ratio between the deformation occurring at the apex as well as 2 millimeters away from the apex. So this ratio increases in softer corneas. The integrated radius, as the softer corneas deform more rapidly and over a wider area, they form a very acute or a steep angle, and the radius of curvature formed in and the area subtended within this acute angle is far much more larger. So in a softer cornea, you will get the integrated radius much more higher. Stiffness parameter was first brought in by Cynthia Roberts, and this is the most sensitive and specific individual parameters unlike the CBI, which is a composite parameter, the next individual parameter which is most sensitive and specific to differentiate between normal and a keratoconic cornea is SPA1. And as the stiffness parameter suggests, it is force upon displacement. Adjusted air pressure at the A1 or the applanation 1 is considered, and the displacement occurring at A1 is considered as a ratio, and the stiffness is calculated. Now this stiffness, as it decreases, it's a softer cornea, and as it increases, it's a stiffer cornea. Ambrosio relational thickness is the only thickness parameter. A lower value indicates a thinner cornea, and a faster thickness increase towards the periphery also indicates a thinner cornea. A special index was derived for post laser vision correction. So a CBI laser vision index was found, and this was developed to differentiate between normal, keratoconus, and post laser vision ectasia. The importance of this was that serial scannings were not required, and one single reading of a CBI LVC was able to tell us and diagnose post laser vision ectasia. Unlike before, you wanted to see the patient serially and then come to a diagnosis of laser vision correction ectasia or a post LASIK ectasia. So a CBI LVC gives us at one go you can diagnose a post LASIK ectasia. So what is the relevance of CBI with the severity of keratoconus and myopia? So Ko and al. Have studied this, and they have seen that the CBI indices were proportionate to the severity of keratoconus, and we studied the Corvus biomechanical index with a degree of myopia, mild, moderate, and severe myopia, and we did not find any association with the spherical equivalent refraction. So the biomechanical index did not change much with the amount of myopia, which was very relevant, because even in high myopic eyes, if the corneal biomechanical index was poor or the corneal biomechanics is poor, then to do a deeper ablation would have resulted in decompensated biomechanics and ectasia. But as we know that there is not much of a difference between mild, moderate, and severe myopia in terms of corneal biomechanics. TBI is an index which was used to detect subclinical keratoconus. Artificial intelligence of random forest was used, and it was found it was much better than the BAD-D or the CBI. And this is an example of a form-fruit keratoconus where the CBI values and the pentacam values were absolutely normal, but only the TBI is deranged. So as rightly discussed before, TBI is more sensitive and more accurate. And as Prima Madam said, it is very weakly correlated with IOP and thickness. So this makes it more independent. Definitely the SSI index is far better than the TBI index. So biomechanical comparative display, the stress strain index. Now this is a stress strain index which gives the intrinsic material stiffness, and as stiffness has two components, the geometric, that is the thickness of the material, and the intrinsic material stiffness. The SSI is the stretching factor and gives a numerical value to the stiffness. So now we can quantitate, unlike the CBI or the TBI where we could not quantitate the difference between mild, moderate, or severe keratoconus. Here now we can distinguish between a mild, moderate, and a severe keratoconus depending on the SSI. And the normal value at 50 years is 1. So in younger individuals, definitely the normal values will be erring slightly on a lesser than 1. So I would just discuss a few cases about the relevance of biomechanics. Now this is a 23-year-old male seeking refractive surgery, having a topography, pachymetry, front elevation, back elevation, which is absolutely normal, with a DP which is borderline deranged of 1.75, but the final D is almost 1.48. Now, here we saw the biomechanical integrated display, which showed that the CBI was deranged, the pentacam back D was normal, the SSI was 0.86, but still we can say this is a softer cornea, and the TBI was deranged. The left eye of the same individual, these are normal 44.3 and 44, not very steep cornea, pachymetry of 513. The relative pachymetry showed 5.7% relative, that was the thinnest area in the inferior temporal quadrant. Front elevation and the back elevation was essentially normal, and the final D was 1.63 and the DP was 1.71. Again, here the CBI was deranged, TBI was deranged, and the pentacam was normal. The SSI again was still more than, it was 0.69, and it was still softer than the right eye. So the pentacam values though were normal, but the biomechanical indices helped us, guiding us to avoid any corneal refractive surgery in this case. Coming to the second case, 24-year-old male seeking refractive surgery with no contributing history. Again, the topography shows a normal topography with a pachymetry of 509, an epithelial map of 56 microns with no thinning, which can be seen on the epithelial map. The DP is 1.82, again borderline final D of 1.65. Again, here you see the CBI, which is abnormal, and the pentacam has a borderline, final D has got a borderline value. The TBI here is normal. It's almost near zero, and the SSI is 0.69. The left eye, again, normal topography, normal pachymetry. The epithelial map, again, here is normal. The front elevation, the back elevation is normal, and the final D is normal. The CBI again is deranged around 0.52, and TBI is normal. This is exactly what Rohit sir said. Sometimes the CBI is abnormal and the TBI is absolutely normal, and here the SSI value is 0.88. Here, since that bad D and the CBI values were borderline, but the TBI being more sensitive and more specific, we relied more on that, and patient was advised for both eyes surface ablation. And down the line, we have followed up with this patient, and at the moment, at 1 year, he is stable. Now, this is the third case where the topography, you can see an asymmetric bow tie, pachymetry of a thin cornea of around 489 microns, 53 microns in the epithelial map. You cannot see any thinned out island on the epithelial map. Front elevation, the black elevation is essentially normal. The D values are normal, the final D values. Again, here the CBI is deranged grossly. The bad D is normal, and the TBI values again borderline. It's nearing 0.29. So here it is absolutely borderline TBI. Left eye, again, you see the epithelial map also showing no thinned out areas on the epithelium map, or the front elevation map, back elevation map is normal. The DT is around 1.67, which is borderline. The final D is 0.97. The CBI is absolutely deranged. The TBI is borderline, and the bad D is normal. Again, here the SSI is 0.98, nearing 1. So we can say this is almost a normal SSI. So since the CBI was abnormal and the TBI was borderline, the patient was kept under observation because I thought the TBI values were borderline. So I have kept this patient under observation. We are serially monitoring this patient for almost 1.5 years. The values have remained the same. And this is a final case where we had topography, pachymetry, and the front elevation was absolutely normal, but the back elevation showed a posterior elevation. Mind you, the specular microscopy was normal, The white to white was 11.4. So it was not a very small cornea also, because sometimes in a very small cornea, you get a steep island on the posterior elevation. The CBI, the TBI was normal. The left eye was absolutely normal, and it was a thick cornea. The CBI, TBI, and the BAT score was normal. The point here was that if just looking at the pentacam on the right posterior elevation, because of the insight of the normal biomechanical parameters, I went ahead and did a femtoLASIK for this patient, and 3 years down the line, this patient is still normal. So definitely in such cases where there is a dilemma, definitely corneal biomechanical matrices definitely can be used as an adjunct to tomography in refractive surgery screening. Corvis ST definitely provides an edge over conventional screening for refractive surgery, and this might help to make a better decision. Thank you so much.
Thank you, Veshal, for that very illustrative presentation. And if there are no questions, are there any questions from the panelists? Or
The only thing is your last case you showed, when you have a thick cornea, the volume of cornea is more, and it's 11.4 on a pentacam. White to white is not that reliable. I mean, it should be around close to 11. So thick volume with a small white to white always gives you a false sign of elevation, which is not a true elevation. It's actually an artifactual issue with the machines.
so thank you so much, everyone, for this wonderful webinar. Sir, Professor Mahipal, sir, would you like to say the concluding remarks?
Thank you very much. I think it was a wonderful webinar. It was really nice to go into the intricacies and the depths and how to interpret it clinically from a clinician standpoint. And I think we had the best of best among the presenters as also amongst the discussants. So I think I wish to thank everyone. I wish to thank Oculus, KLB, Dr. Namrata, and Dr. Rajesh for helping us, and obviously the wonderful speakers that we had, Dr. Tommy, Dr. Professor Ko, Dr. Prema, Rohit, and Vishal. Dr. Kenya. So I think overall, let us hope that we can put it to good use in clinical practice. And as we all know that today a back surface topography has become almost an essential tool with all of us, as also now the biomechanical machines have also become an integral part, and the combination of the same. I think one day we should have a machine which can do almost everything, which can also do an abrometry, maybe combine an eye trace with a equivalent of a pentacam, as also the Corvis, as also an autoref or a keratometer. So if we have a combination of everything put together, obviously the companies wouldn't do it because they want to sell the machine separately. But I think it is quite possible to integrate and have one good machine which can give you almost everything that a patient wants, and so that the and some form of artificial intelligence, so that the results are out on the table to the ophthalmologist. So let's hope that's what's there in the future. And thank you everyone for participating in this great webinar. And thank you very much to the organizers. And Dr. Namrata, you can give your final vote of thanks.
We would like to thank the sponsors of this who organized this webinar, particularly KLB and also Oculus, and Mr. Divakar, who's been really active to get us all on the same platform, working for last couple of weeks. So thank you everyone. Thank you, Dr. Shizuka. I know it's late in your country. And thank you, Tommy Chan. And sir, Dr. Tityal sir, would you like to say something before we conclude?
So I would have a same thing what Professor Mahipal talked about. In fact, it was great learning for us also to look into all complex cases and know the new technology. As Vishal talked about, its application is not only in the refractive surgery. Dr. Namrata summarized its application in future in various case scenarios right from pediatric cases to corneal surgeries, which will have a real impact. We know that even after keratoplasty, we do have a lot of changes happening in the cornea, and sometimes ectasia do happen despite doing a good keratoplasty in these cases. Cross-linking, which I think the entire thing which is talked about, what is going to happen, the collagen is going to be relayed after a few years, and what is the impact of all these things will require a biomechanical tool. And I also have the same thoughts what Dr. Mahipal talked about, future machines, which might pick up things much better for us and decrease the complication of such a beautiful surgery in cornea, which we have been doing. And I would again thank the sponsors, KLB, AIOS, for getting me into this learning phase for such a new thing, new technology. Thank you again.
Thank you, everyone, and thank you, the audiovisual team, Mr. Sunil, Mr. Kripal, Ms. Raki, who are at the back end and managing this. Thank you so much.
Thank you. Thank you.